Odontoid is a fracture can happen at the level of C2. Odontoid fracture can be classified into three different types. Type 1 is the one which is the tip fracture. These fractures can be associated with ligamentous injury itself of the transverse and apical ligaments and making it unstable at times. Type 2 fractures are the one at the watershed area. This is the metaphysio-diaphyseal area of the odontoid bone. These fractures are rendered unstable and can go to non-union as there is a precarious blood supply. The third one are the one which are down at the metaphyseal level and has a good blood supply and are managed conservatively. So type 1, if the ligaments are stable, can go on for conservative management. If they are unstable, they might need cervical fixation posteriorly, or a screw can be placed if needed. The screw can be transoral odontoid fracture fixation. These are specific type of fractures which are called anterior apical oblique fractures, which makes the screw trajectory horizontal to the fracture side and fixation can be possible. Other way around, if the fracture fragment is too small and displaced, it can be removed. The C2 fractures are managed conservatively. If they are stable, they can be managed with cervical brace. If they are unstable, it can be placed in a halo. Union rate is good in these fractures. Union rate is bad in these fractures. So these patients see the cervical type 2 or the type 2 fractures are managed operatively. The fixation is similarly with the posterior approach or anterior with transodontide approach. The controversy exists regarding adult population because the fractures are unstable and goes towards non-union. Patient can go into myelopathy. Moreover, conservative management of the halo waste, the patient older patient cannot tolerate that and is high risk of aspiration pneumonia and death. However, any fracture which happens in the odontoid fracture, specifically C2 fractures, type 2 fractures, there are risk factors. If the displacement is more than 5 mm, age is more than 50, delay in treatment more than 5 days, angulation of more than 10 degrees, and a previous history of smoking, these are risk factors that the patient will go into non-union. Recently, Cochrane study in 2008 showed that there is no difference between surgical and non-operative management for these fractures. Regarding the surgical approach, as I said, you can do a transoral odontoid screw fixation. You can do posterior C1 to C2 fusion with the articular screws. You can do set C1 lateral mass fixation with C2 pedicle construct, or you can do odontoidectomy. So the stability can be confirmed by number one, the classification itself. The type 2 fracture, as per Anderson and Alonso, are mostly unstable fractures. Number two will be the orientation of fracture. Apical oblique fractures are mostly unstable fractures. Number three, atlanto-dens interval is important. If this more than 4 mm, this means that the transverse ligament has been disrupted, rendering it unstable, which can be confirmed by MRI. And number four is that if it's highly anticipated to get displaced with the passage of time. Number five would be pay any patient which will be deemed inappropriate for management of conservative with halo, for example, with chest injuries.